All right, so my name is Tiffany Keith, and I am one of the program managers for the Office of Diversity and Inclusion. Welcome, and thank you for joining us for our Disability Awareness Month event. Today, we have Dr. Craig Escudï presenting his research on fostering health equity for people with intellectual and developmental disabilities. Dr. Craig Escudï is a board-certified fellow of the American Academy of Family Physicians and the American Academy of Developmental Medicine. He has more than 20 years of clinical experience providing medical care for people with intellectual and developmental disabilities, also known as IDD, and complex medical and mental health conditions, serving as medical director of HUSPED Regional Center in Mississippi. While there, he founded the Developmental Evaluation Training and Educational Consultative Team of Mississippi. In his current role as president of IntellectAbility, Health and Wellness, a company that develops and provides health risk reduction tools and training to improve health and wellness in people with IDD. He speaks regularly nationwide about healthcare issues relating to people with IDD in effort to facilitate better health outcomes for both clinicians and patients. He is also the author of Clinical Pearls in IDD Healthcare and developer of the curriculum in IDD Healthcare, an e-learning course used to educate clinicians on the fundamentals of healthcare for people with IDD. Just some housekeeping before we get started. This session will be recorded and posted to our social media platforms. This session is also eligible for social work continuing education credits as well as psych continuing education credits. We encourage everyone to stay to the end to get those full credits. Please note, if you are seeking psych CEs, there will be 2 check-in links provided in the chat at the 15-minute mark and another closer to the end of the presentation. There is also closed captioning available to access. Please click on the live transcript tab at the bottom of the screen, click show subtitles, and you will be able to see those closed captionings. We also have Q&A available. If you have any questions, please put them in the Q&A and we will answer them towards the end of the webinar. So without any further ado, I will hand this over to Dr. Craig Escudï.
Thank you very much, Tiffany. It's a pleasure to be here with everyone today to talk about something that's very near and dear to my heart, which is how can we foster health equity for people with intellectual and developmental disabilities. I'm going to get started right away with a story about Mary. Mary was an older lady who lived in a residential setting, who began having some fever and some coughing and developed pneumonia and ended up having to be transferred to the hospital. She was admitted to the intensive care unit with the diagnosis of pneumonia, and she remained there for a few days, and we got word that Mary had been placed on hospice. So I placed a call to the hospital and tried to find out more information about what was going on with Mary. And they told me that her pneumonia had cleared. She had completed her course of antibiotics. She was not requiring oxygen. However, Mary just wasn't eating, and she was old and she has just a lot of disabilities, and just really has a poor quality of life. So we just felt that Mary was, the best thing for her was hospice. So that was a story that was told to me by the hospitalist. And I again confirmed that Mary had recovered from her pneumonia and that she could be discharged from that standpoint, and asked that she be discharged back to her residential program, where we promptly found that Mary had a large fecal impaction, which is a big problem in people with intellectual and developmental disabilities. And when she got back to her residential program, we took measures to relieve that. And she was in a familiar setting. Mary began eating well and went back right to her normal quality of life for her, which was quite good, where she enjoyed life for another several years. So that's kind of a story to illustrate maybe that we need to think differently about people with intellectual and developmental disabilities and how we address healthcare issues and healthcare needs. We talk a lot about health equity and health equality, and I just want to touch on the differences between the two. When we talk about equality, that means everyone has access to the same thing. Mary had access to ICU care and all that everyone else had access to. Mary had access to healthcare providers, but I would argue that Mary maybe didn't have access to a healthcare provider who understood the needs that Mary had as a person with an intellectual developmental disability, understood the different ways that Mary might communicate things, or that understood the different types of issues or problems that Mary might face. And certainly that didn't really necessarily understand that a different quality of life doesn't necessarily mean a worse quality of life. So in order to have health equity, the idea would be that everyone would have access to the type of healthcare or the type of setting that could provide the same level of healthcare to everyone. A good example of this is a scale. Maybe everyone has access to a scale, but that scale requires someone to stand up to be weighed. So they might have equal access to a scale, but it's not equitable because everyone can't be weighed on that same scale. So equitable access would mean that there would be a scale available that could weigh anyone. So health equity is achieved when no person is disadvantaged because of a social position, a disability, or any other circumstance. When we talk about health disparities in people with intellectual and developmental disabilities, the term health disparities refers to preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. In 2022, the National Council on Disability released a document called the Health Equity Framework for People with Disabilities. And it really talked about how people with disabilities are at significant risk for these health disparities. And these are some of the things that were mentioned, that people with disabilities have a shorter life expectancy. They're 3 times as likely to have arthritis, diabetes, heart disease, 5 times more likely to report a stroke, COPD, or depression, and they're significantly more likely to have unmet medical, dental, and prescription needs. They're more likely to receive poor maternity care, which can result in more severe pregnancy and birth-related complications and maternal death. They're more likely to be obese and less likely to have screening exams, such as pap smears and mammograms and prostate cancer screening exams. And when we add in the additional differences such as race or ethnicity, these risks are magnified on top of that. The pandemic that we've all experienced, that we're all well aware of, really highlighted some other inequities in this area. People with intellectual and developmental disabilities were at higher risk for being triaged out of COVID-19 treatment when supplies or personnel were scarce. They were denied the use of personal ventilators and other assistive devices that were needed for critical support during hospital stays. And crisis standards of care targeted people with certain disabilities for denial of care. We saw that people were deprioritized from things like ventilators or from ICU beds if they had a developmental disability. And these health disparities are deadly. We know that people with IDD, after some recent studies have shown, had the highest independent risk factor for contracting COVID-19. And they were having an intellectual disability is secondary only to age for dying from COVID-19. And people with intellectual and developmental disabilities are 6 times more likely to die from COVID-19 than those without them. Those are pretty sobering statistics. Disability bias, when we talk about the bias, we all have biases to different things, but biases against people with disabilities contributes to health disparities. So these are often negative perceptions and inaccurate assumptions about the quality of life of a person with a disability. And we saw that in the example that I gave you with Mary, that the clinician felt that Mary's quality of life was just not that good. And so, let's just move her to hospice. These things are often unconscious. They're not overt. They're often unconscious biases, and healthcare providers are certainly not exempt from from these types of deficit-based perspectives. And they have a high level of influence in healthcare decisions because they're very influential in the type of healthcare that is delivered to different people. And this can lead to healthcare providers to believe that preventive and other care is really not necessary for people with disabilities. We've certainly seen this in a number of different ways. Now, one other thing I want to address is sometimes when we hear clinicians talking about healthcare issues and taking care of health and wellness for people with intellectual disabilities, it gets kind of lumped into something called the medical model. And I would say that misconceptions about what the medical model actually is can contribute to health disparities. So in the medical model, this is an outdated view of disabilities that has really been long gone. Some people may still fall into that, but certainly it's not accepted, where the disability is seen as a defect that must be fixed. So looking at it medically, how can we fix this defect in this person? We've progressed away from that to the social model. And the social model looks at the environment and all of the other circumstances around people and recognizes that what we need to do is promote an accessible environment for everyone, with or without a disability, so that they can receive equitable health care. So when we talk about trying to improve healthcare, improve health and wellness, to teach clinicians about how to provide healthcare for people with disabilities, it's actually in direct opposition to the medical model. We're not trying to fix the disability. We're trying to make sure that people with intellectual and developmental disabilities can have equitable healthcare, can have access to clinicians who understand how to provide healthcare to people with intellectual and developmental disabilities. So as I said, attaining disability clinical competency among clinicians is in direct opposition to the medical model. And disability competent healthcare providers are those who receive education in disability competent healthcare practices, who understand the risks associated with diagnostic overshadowing. I'll touch on that in just a second, and who recognize and address unique clinical presentations that people with intellectual and developmental disabilities have. When I teach clinicians about providing healthcare for people with IDD, I'm usually not teaching them about the specific condition and how to treat it. For instance, how to treat aspiration pneumonia, or how to treat constipation. Most clinicians are aware of those things, but they often present very differently. There are different risk factors associated in people with intellectual and developmental disabilities. And that's the part that I believe is so important that we teach all healthcare providers and clinicians. And those who are disability competent, they appreciate and promote optimal health and allows people with IDD to live longer and healthier lives, and see people with IDD as people first. And that is very important. So I mentioned the term diagnostic overshadowing, and this is something that contributes to health disparities. The Joint Commission, which you're probably very familiar with if you work in a hospital setting, it's a large accrediting body and sets standards for healthcare agencies and organizations. They put out very recently, in June of 2022, a Sentinel event alert that specifically talks about diagnostic overshadowing and how it contributes to health disparities, and specifically mentioned people with intellectual and developmental disabilities and how they're more prone to it. So what that means is that we often see, say, behavioral changes in a person with a disability who maybe can't necessarily communicate that they're feeling pain, but they're experiencing pain, so they may have some varying behaviors. Well, what happens many times is the person may present with these adverse behaviors, and a clinician may look at them and say, this is just what the person with disabilities does. Sometimes they hit themselves or they hit other people. So what we need to do then is put them on a psychotropic medication to help reduce that behavior. rather than doing an assessment and looking for other potential causes which might be causing that problem. So the diagnosis, the intellectual and developmental disability diagnosis, overshadows the actual diagnosis or the condition that might be going on. The person may be having a dental abscess that is causing them a lot of pain, and they aren't able to tell anyone. So they act out, or they might spit out food because it hurts when they chew, for instance. And though to the untrained clinician, they may see this as, well, this is just what people with disabilities do. Let's put them on a medication to try to control that behavior. So that is a big issue, and the Joint Commission brought that issue to the forefront. It's something those of us who have worked in the field have been aware of for quite a long time. So the Joint Commission states that diagnostic overshadowing is a failure to deliver a proper diagnosis, and indeed it is. And that it signifies a departure from clinically accepted principles of developing a differential diagnosis. Again, if we simply say, oh, this is due to the disability, then we're not developing a differential diagnosis as to what might be actually happening and can hinder the ability to deliver a proper diagnosis. And it happens because most clinicians do not have the training, experience, or skills in treating people with intellectual and developmental disabilities. I was certainly one of those when I started in this field. I had no training or experience, and realized very quickly how ill prepared I was to provide healthcare to people who really needed good healthcare. I learned a tremendous amount over the next several years from staff, nurses, and others who had been working in this field for many years, and that's how I really became passionate about providing education and training to clinicians to try to prevent preventable issues, preventable healthcare issues, to prevent people from suffering needlessly and dying needlessly from treatable conditions simply because we weren't trained. And not being trained is not necessarily unusual. I mean, if you came to me, I'm a family physician. If you came to me for a heart surgery, you probably would not do very well because I don't have the training. So we need to be careful not to say to blame clinicians in a way, but we need to do what we can to promote training wherever we can to ensure that they receive the training that they need. So gaps in preventive care contribute to health disparities as well, too. And this is not something that's new to the pandemic. The pandemic highlighted issues with gaps in preventive care for many people because many people quit going to their clinicians out of fear of being around others who had COVID-19 and not wanting to contract it. So there's a lot of people who deferred preventive care. But even before the set of the pandemic, only 1 in 4 Medicaid beneficiaries of appropriate age had a colonoscopy in the past 5 years. Less than 50% of adults who should have received a cervical cancer screening in the past 3 years had one. And these differences were found, in health screening rates among adult Medicaid beneficiaries by race and ethnicity as well. So certainly the pandemic contributed to it, but it was a problem that existed before. In terms of people with intellectual and developmental disabilities, often it was thought of, well, this person's not going to live that long, so maybe they don't need to be screened for a lot of things. Or this person is simply non-compliant with the procedure, rather than looking for ways to help ensure that the person, looking for different approaches that can help ensure the person gets the screening that they need. In a 2021 survey of 700 adults age 50 plus with chronic conditions, we saw these impacts here from COVID-19. Lower illness, self-efficacy, physical activity, and less healthy food intake. 43% had worsened sleep, 20% had difficulty obtaining medications, 60% had difficulty receiving routine care, 19% delayed essential medical treatment, 64% delayed preventive care, 43% avoided contact with providers about physical health concerns. and 13% avoided reporting mental health concerns. So there were a lot of things that the pandemic did contribute to in general. And again, these are often issues that are found in people with intellectual and developmental disabilities even prior to the pandemic. So gaps in preventive care are magnified for people with IDD. They are already less likely to get preventive health care than people without intellectual and developmental disabilities. And you add these changes to it, and it amplifies it. There's a higher incidence of chronic medical conditions, including obesity and asthma and diabetes in people with intellectual and developmental disabilities. And they're at greater risk for negative long-term health outcomes, disability bias, and health disparities. And they often receive, as we mentioned, care from providers who have not received the education to provide IDD competent health care. So preventive measures, preventive care also contributes to health disparities. And I know I'm painting a gloom picture here, but bear with me because we're going to talk about some ways to improve these things a little bit later. But before that, let's talk about social determinants of health. And we know that this impacts health for everyone as well. These are conditions in the environment where people are born, where they live, where they work, where they play, where they worship, and that affect a wide range of health and functioning and quality of life outcomes. It impacts health and it impacts quality of life. It looks like they can affect social determinants of health can affect as much as 80% of health outcomes. So why should we be concerned about them? Because people with IDD are more likely than people without ID to have unmet social needs in these areas. And we'll touch on those in a minute. And here's the statistic I just mentioned. It's estimated that 80% of health outcomes are related to a person's physical environment. They're social determinants of health and health-related behavior. So if we can do things to improve these areas, we can do a lot to help improve health and wellness as well. So when we're talking about social determinants of health, there are 5 big areas. So economic stability, education, healthcare access, neighborhood and built environments, and social and community context. Let's delve into those just a little bit more and also relate them specifically to people with intellectual and developmental disabilities. So when we look at economic stability and employment, prior to the pandemic, we know that there are issues with people not having jobs during the pandemic, but even prior to that, 81% of people with IDD do not have a paid job in the community. This percentage has remained relatively unchanged over the past 10 years. And many states still allow people with IDD to be paid sub-minimum wage, which doesn't help their economic stability. And many people say, yes, this person volunteers, and it's great. Volunteering is a valued community activity, but it's not employment, and it doesn't reduce the impact of poverty. So helping ensure that people with IDD can be employed and can be employed at a fair wage can certainly improve this particular social determinant. Education, access, and quality. So we know that people with IDD have higher levels, people with higher levels of education are more likely to be healthier and to live longer. And students with disabilities who are bullied are less likely to graduate or get a good job and are at higher risk for heart disease, diabetes, and depression. Students with IDD have the lowest rates of engagement in post-secondary education and work after high school. But there is progress being made, which is great. And there are currently about 6,000 students with intellectual and developmental disabilities that are enrolled in about 300 plus colleges and universities. And we're seeing more colleges and universities providing and creating and developing programs to help people with intellectual and developmental disabilities successfully attend post-secondary education, which is excellent, which can help this social determinant. Healthcare access and quality, we touched a little bit about this already. People with intellectual and developmental disabilities are less likely to get preventive healthcare services that they need. They have a higher incidence of chronic medical conditions like obesity and asthma and diabetes. They're at greater risk for negative long-term health outcomes, as well as disability bias and health disparities. And again, they often receive healthcare from providers who have not received specific education in this particular area. We talk about neighborhood and the built environment. So the neighborhood where we live has an impact on our health and our well-being. Many people with disabilities have very limited incomes, which can make it challenging to find safe places and healthy places where they can live. It can be a significant challenge. They can have our access to subsidized housing can often be limited, and there can be a very long wait list. It can take a very long time to obtain. And funds available to support people with IDD in community. So we're talking about waiver funds and long-term services and supports that can be available. Those funds cannot be used to pay for room and board or living expenses or housing expenses. So that further, creates more difficulty. And people with physical disabilities may find challenges accessing homes that can be modified or that already have been modified to make them more accessible as well too. And then social and community context. It's already known that relationships and interactions with others can certainly have a major impact on our just general, the way we feel and our health and our well-being and our mental health. And people with intellectual and developmental disabilities often are not well integrated into their communities, and they may struggle with social interactions to begin with, which can make relationship building a challenge. And some challenges and dangers, can't necessarily be controlled, such as an unsafe neighborhood or discrimination. And we know that people with IDD are already at higher risk for abuse and neglect and exploitation, about 7 times higher the likelihood of being abused if you have an intellectual or developmental disability than those who don't. So you put all of these things together, all of these social determinants of health, and you can see that people with intellectual and developmental disabilities have even a greater disparity in many of these areas. Now, when we talk about healthcare needs of people being met or not being met, if you look on the left here, when healthcare needs are not met, so people are not getting the healthcare that they need. They're experiencing higher levels of health issues. Their chronic disease burden risk goes up. Their overall health risk goes up. We see more people utilizing emergency rooms, emergency departments, and hospital admission visits. Those all can go up. We see increased functional disability. If our health is poor, if we have diabetes and we lose a leg, our functional ability goes, our functional disability goes up. If we're ill, we aren't able to do as much as we maybe would be able to as if we were not ill for ourselves. That increases costs as well too. Both Medicaid programs and long-term supports and services costs go up as well too. And the things that decrease are the quality of life of a person. You've heard it said, if you don't have your health, you don't really have anything, right? Health of the Medicaid program, actually, because many people are on Medicaid and the expenses go up, the opportunities to bend the Medicaid program cost trend or to reduce costs goes down. And the overall health of the state's population or the country's population goes down as well too. So when we look at the causes of health inequity for people with IDD, just kind of a little recap of this segment. We talked about health disparities and how they are already there and how they exist. We talked about disability bias and how perceptions and misperceptions of people with IDD can affect their overall health. We talked about the untrained healthcare workforce having an impact. We talked about misusing the term medical model. And sometimes if people hear the word medical model, then they automatically shut off to thinking about anything about education. We talked about diagnostic overshadowing and the dangers of diagnostic overshadowing in causing misdiagnoses and people suffering needlessly or dying from conditions that could have been prevented or treated. We talked about gaps in preventive care and how preventive care is already lower in people with IDD, and the pandemic heightened that, and how unaddressed social determinants of health have an impact as well too. So we can see a lot of health inequities, but a lot of challenging areas means that there are many areas for improvement, right? So I'm going to take a sip of water and then we'll talk about some tools and solutions. All right, so what can we do to address these health inequities for people with intellectual and developmental disabilities? Well, let's talk about a few things. There's a resource out there for addressing or identifying social determinants of health. And it's a screening tool that's put out by the American Academy of Family Physicians. And it's a relatively short 15-question questionnaire that you can administer to the person with the disability and the person who's with them, supporting them, that can give you some indications as to areas that may need to be addressed in terms of social determinants of health. Now, let's say you find that a person has a risk in a particular area. How can we find resources? So there's a very interesting resource with an interesting name called Aunt Bertha. Aunt Bertha is a resource that provides specific information about many different social determinants of health. For instance, if you go into Aunt Bertha and you put in a zip code where a person lives, you will get recommendations for things like food pantries, for shelters, for housing assistance, for employment assistance. And you would be amazed at the number of things that you can find using this. So let's say you as a clinician have a person that you've identified that is having some trouble finding a job. Then you can go into Aunt Bertha, put in that person's zip code, and you'll find a listing of a number of resources. If you just look up Aunt Bertha and social determinants of health, you'll find that there are a bunch of different resources. The link at the bottom gets you there as well too. So when we look at social determinants of health and we look at the life of people with disabilities and the quality of life with people with disabilities, is there improvement, or when these things are addressed, can it actually improve the person's quality of life? And to illustrate that, I'm going to turn to some data from the Council on Quality and Leadership, or CQL. They developed a Social Determinants of Health Index, which looks at choice and engagement, about how people interact in their community, how they perform different social roles, people who have the opportunity to choose where they work, where they live, so on and so forth. It looks at person-centeredness, where people have the ability to exercise their own rights, if they're treated fairly, and if they experience continuity and security in their lives, and also health and safety. And I'm going to point out a few statistics here. So this one here talks about social determinants of health and the impact on emergency room visits. And there are a number of statistics here, but if you look at the big ones there, the number of emergency department visits for people with intellectual and developmental disabilities was 66% lower when people experience continuity and security in their lives, 57% lower when supports enhance dignity and respect, and 40% lower when agencies implemented ongoing staff development. So agencies who provide support for people with intellectual and developmental disabilities, when they implement staff development, it reduces emergency room visits. It's 90% lower when people participated in life in the community. 63% lower when people had meaningful work and activity choices. And 61% higher when people had direct support staff turnover within 2 years. So if people had support staff or direct support staff who provided assistance with their activities of daily living on a regular basis, if they had higher rates of turnover, their emergency room visits also went up. So very interesting statistics there. When we look at it in terms of social determinants of health and the impact on injuries in people with intellectual and developmental disabilities, there were 63% lower injuries when organizations facilitated people's desires for natural supports. That means supports in a community type setting rather than just paying people to support someone. 54% lower when organizations respected people's concerns and responded accordingly when they were treated with dignity and respect. 60% higher injuries when people had direct support staff turnover within 2 years. 61% lower number of injuries when agencies implemented ongoing staff development. So staff training and staff development is very important. And 53% lower when supports and services enhance dignity and respect. And in terms of challenging behaviors, this is an issue that we hear about a lot in people with intellectual and developmental disabilities, where we talk about this person having these challenging behaviors and we need to do something about it. The first thing I'll say to do about it is to look for an underlying treatable medical cause, which is often the case. But in terms of the social determinants of health impact, CQL found that these challenging behaviors were 89% lower when people were free from unnecessary and intrusive interventions, 87% lower when organizations provided each person with continuous and consistent services, 74% lower when people had meaningful work and activity choices, 83% lower when organizations treated their employees with dignity, respect, and fairness, and 61% lower when staff were trained to promote dignity and respect and recognize individuality. That's something we call person-centered training, where support staff are taught to provide support in a way that balances what's important to a person and what's important for a person. And when people have more choice in their lives, they're less likely to have challenging behaviors. And think about that. If you were forced to work in a particular place, or to live in a particular home, or to live with particular roommates, and you had no other options, you might experience some challenging and aggressive behaviors. It just makes sense. So going back to some tools that we can use to help with these things. When we talked about preventive care being a risk, preventive care being a reason for health disparity or lack of preventive care, the U.S. Preventive Services Task Force is an independent volunteer panel of national experts in disease prevention and evidence-based medicine. And they make evidence-based recommendations. And you can find these recommendations by looking up U.S. Preventive Task Force. People with IDD have the same need for preventive services as everyone else, but this often goes unrecognized by some healthcare providers, or they just simply say that the person couldn't be examined rather than looking for other ways to examine them. But it's important to recognize that there are guidelines for these, and there are some specific preventive guidelines for certain conditions as well, too. There's a mobile app that you can use if you are working with people with intellectual and developmental disabilities and you're advocating for them to get preventive screening. You can certainly pull up your app here and look and see what screenings are recommended for a person of a specific, age and sex, and you can present that to the clinician and say, "Hey, doc, here are the recommendations for Johnny. He's 45 years old. These are the things that he should have. How might we go about scheduling these?" And you can help advocate for preventive measures to occur or to happen. Now, again, it's not meant to replace clinical judgment. These are all recommendations, and sometimes there may be good reasons not to do something. But a good reason not to do something is not that the person has an intellectual disability. That's simply not a good reason. There are tools for consumers that are a little less clinically based that can help find preventive measures as well, too. You can go to My Health Finder and find individualized, personalized recommendations for preventive services, and lots of information on different topics as well, too. So another resource to help learn about preventive measures. Cross-sector collaboration is also important when we address the complex care requirements and create new partnerships among entities that have not typically worked together. And when we work together, oftentimes we can build on each other's strengths. So maybe the healthcare sector, along with public health agencies and maybe some community-based organizations, can work together to promote health and wellness and to reduce health disparities in different ways. They can provide clinical care that can be targeted health-related or social service, health-related social services that can improve health for people with intellectual and developmental disabilities. So hospital systems, coordinating with clinic systems, coordinating with homes for people with intellectual and developmental disabilities, and forming these partnerships and providing training and education and support can certainly help overall as well, too. Now, you heard me mention earlier in the talk about the National Council on Disabilities Health Equity Framework. In that framework, they put forth recommendations that they felt needed to occur to help improve health and health care for people with intellectual and developmental disabilities. There were 4 core competencies or 4 core pillars for addressing health disparities that they mentioned, and there are about 35 additional ones. So I would encourage you to take a look at that report to hear about all of the other ones. But I do want to mention the 4 core issues. The first is that they recommended that people with disabilities be designated as a special medically underserved population. When you're designated in this manner, it opens up lots of research and funding dollars and opens up clinical trials as well, too. So that was one recommendation. The next recommendation, their second one, was to require comprehensive disability clinical care curricula in all U.S. medical, nursing, and other health professional schools, and disability competency education for practicing clinicians. When I saw this one here, this was like someone had pulled this out of my brain, because this is what I've been advocating for many, many years now. I learned firsthand what it's like not to be trained and to be providing healthcare for people with disabilities. And really, it is my mission to provide training and education to healthcare providers. And this is so valuable and so important. The other 2 mentioned here are to improve data collection concerning healthcare for people with IDD across the lifespan. We know that people with IDD are excluded from a lot of trials, and there's not enough data out there when you really go looking for things sometimes to support good practices and others. And also to require the use of accessible medical and diagnostic equipment. This again is looking at the environment to make sure that the environment can provide an equitable level of healthcare. Being weighed on a scale, being able to get a mammogram, so on and so forth. The equipment should be accessible for everyone. So I'm going to touch more on that second one about comprehensive clinical care curricula and let you know some things that are actually happening out there right now. So there is an organization called or an entity, I guess, called the Path With program. It's partnering to transform health outcomes with persons with intellectual and developmental disabilities. It's a cross-sector consortium of advocates and healthcare providers, community-based workers, and leaders in the healthcare field that are working to develop and integrate inclusive learning activities in the form of interprofessional education. One of the things that is very important in providing healthcare for people with disabilities is to have a relationship between a number of healthcare providers, this interprofessional education, because we really need to have an integration between medical care and behavioral care, for instance, because there's so much crossover in everyone, not just people with disabilities, but it's even more profound in people with disabilities, where behaviors, as I mentioned, might have a medical cause, or they might have a social cause, or an environmental cause, or all 3 of the causes. And so having this interprofessional education to promote IDD healthcare competent workforce is very important. So there's this organization that you can look into. The American Academy of Developmental Medicine and Dentistry is an organization which focuses on improving healthcare in medical care and dental care for people with intellectual and developmental disabilities. They have a national curriculum initiative in developmental medicine to integrate developmental medicine curriculum into medical schools. Their goal is to get it everywhere. They've reached about 20 medical schools so far. So that's another great organization to look into and become involved with. The Institute for Exceptional Care is a relatively new organization which has come about. And one of the things that I like about this organization and the work that I've done in this organization, it's not only looking to improve health education, which is an important component of it, but it's also looking at things from the payer side. How can we foster payer systems like managed care organizations and insurance companies to pay for the care that's needed for people with intellectual and developmental disabilities? Sometimes visits, take longer. Sometimes there are special procedures or other things that need to be done. So we need to work both from the educational side of things and from the payer side of things to build a system that can improve health and wellness for people with IDD. And then the other thing I'll mention is something that I've been intimately involved in is the curriculum in IDD healthcare, which is out there, which is created to provide clinical information and clinical skill sets and the fundamentals of IDD education to healthcare providers. It's currently being used in a medical school, a couple of nurse practitioner schools, as well as a couple of states that are providing it to practicing clinicians to improve the competency of clinicians to be able to provide healthcare for people with intellectual and developmental disabilities in a more informed way. So it's a lot of talking, a lot of information. I'm going to conclude with a few statements here, and then I encourage you to type in questions in the chat box. I'm very happy to answer any questions that you have or provide any more information. So begin thinking about questions you might have. So we talked about the fact that people with IDD are at risk for health disparities, which could lead to poorer health outcomes, a poorer quality of life, and early death. But many of these negative outcomes are preventable. There are things that we can do about them. And each one of you can make a significant difference by advocating for and supporting them to access competent healthcare, appropriate healthcare that's delivered in a timely manner and improving social supports as well. So I hope this has been informative. I hope you have gained some insight. I hope you have some things that you can take home that you can look at and that you can use. And I hope you use this information for yourselves in the work that you do in providing support to people with intellectual and developmental disabilities, and share it with others as well. So with that, I will open it up for questions, and let's see what we have here. Let's see, we talked about equity, equity care and we know people with IDD have special needs. For those who have trouble, how do we create an equitable space without othering? I'm not sure, that may be a mistype there. But I'm not sure exactly the question, but I think the idea is to create an equitable space for anyone. And there's something that you can look up. It's called universal design. And it's about designing the environment to make it accessible for everyone. A simple example is having a ramp available everywhere instead of steps. But there are things you can look at that can help ensure that areas are more, I guess, equitable or more accessible is the word I was looking for everyone. And again, I'm not clear on the full question, but if you want to elaborate, please go ahead. Overshadowing versus health disparities. Have we seen data on the direct correlation between the two in people with IDD? I'm not aware of specific data that differentiates between those two things. But no, I'm trying to think. I've got a couple of things bouncing around in my head, but I can't think of any specific data in a direct correlation. But there's a lot of information out there, in a lot of certainly a lot of anecdotal information about missed diagnoses. There's a lot of evidence out there about the overuse of psychotropic medications, which are being used to treat behaviors. About 2/3 of people with intellectual and developmental disabilities are on some sort of psychotropic medication, but only about 1/3 of them actually have a psychiatric diagnosis, which tells you that a lot of medications are being used to treat something else besides the psychiatric diagnosis, and usually it's some sort of adverse behavior. And many of those times, those adverse behaviors, you can find an underlying treatable cause for them from a medical standpoint. Let's see, other questions here. Wow, what is a quick tool that we can use to ensure that we're addressing our unconscious biases with people with IDD in the moment? Somebody may have to jump in here and answer this question. There is a tool, and I think it's put out by Harvard Medical School. I'm not 100% sure, though, that you can do a kind of a bias self-check that can be quite interesting. And I would encourage you to look at that. Look up IDD unconscious bias screening tool, I guess. And if you take that tool or take that quiz, it can provide some insight into how you may be unconsciously biased in one way or another. And it's not just specific to IDD, there's racial and other types of quizzes in there too, but that might be something that can help us look at our own biases. Let's see, have you seen a shift in the culture of medical institutions and clinicians to move toward better equitable spaces for people with IDD? I would say yes, and that's been very encouraging over the years that I've been in this field. I definitely have seen that. I've seen more healthcare institutions interested in this area. I've seen more healthcare institutions implementing programs, especially in terms of people with autism, trying to create an environment, say a different waiting room environment or a different office room environment for people that are known to have some sort of intellectual and or developmental disability. I've seen teams that have been created by some healthcare organizations that can be kind of deployed when there's a person with an intellectual disability or some other types of social, difference in their abilities to address some of the needs differently. So I have seen more things happen, but I can also say that there's a long way to go. We definitely have a long way to go, but it's been very encouraging. What's been really encouraging to me is to see that there's been more emphasis in the past, I'd say 3 to 5 years, in terms of grants that have been made available and programs that are out there to promote healthcare equity for people with IDD, and specifically to focus on training of healthcare providers. Regarding payers, how do we become advocates? Well, learn as much as you can. And I would say also look at IEC, the Institute for Exceptional Care. Dr. Mai Pham is the president and director, and she can probably point you to ways that you can learn more and be of assistance from a payer side of things as well. Let's see. There's one other comment here. I think we have. How are we doing on time? We got a couple of minutes. So let's look at this one. Just today in the New York Times ran a story that highlighted, among other things, clinician frustration about scheduling overruns and working with patients with disabilities in general, resulting in disrupted clinic flow and additional costs. Can you comment on how scheduling can be adapted to afford patients with disabilities and their clinicians the time necessary to conduct an adequate visit? Yes, I can comment on that. There are a number of different approaches. One of the first things is that it's important for the clinician's office to know that the person has a disability. So when I'm speaking to groups, not provider groups, but groups of people who support people with disabilities, I encourage them to say, when you call to make an appointment for this person, let them know that this person has an intellectual disability and you may need to schedule additional time. That's an important thing. Sometimes appointments get scheduled and we really don't know what the extent of the problem is. So having that information can be very helpful in scheduling. A couple of other options is that if you have a clinic if you have a clinic that sees people with intellectual and developmental disabilities, you might set aside maybe the first hour in the morning for appointments for people with disabilities, or the first hour after lunch, which can eliminate some waiting time or things like that, or maybe at the end of the day. I mean, there are different ways that it can be done. I've seen some people schedule an intellectual and developmental disability half day, or a full day every week or two, where they know that when it's not an urgent situation, that they will have scheduling and they'll have longer appointment times specifically for people with intellectual and developmental disabilities. So those are just a few things that I've seen. But you're right, it does take more time often. Situations can be more complex. Getting information can take longer as well too. Sometimes you have a staff that comes with a person that doesn't know a lot about that person, and that person can't always answer for themselves. So there can certainly be challenges, but I think the biggest thing is to be aware that you often will need to schedule more time for a person with a disability. And in terms of funding for those things, there are higher levels of coding that you can do to be reimbursed for things that are more complex. So that can be compensated for in some way as well too. So that is all the time that I have. I'm very appreciative to all of you who stayed and listened to this. I hope you took some tidbits home with you that you can use. And I'm going to turn it back over to Tiffany.
All right. Thank you so much, Craig. And we want to thank everyone who, again, stayed. It's really, really special thanks to you, Craig, because this was a great presentation. I think it touched on a lot of important points in regards to working with people with IDD. So thank you again for this presentation. So we do want to hear from everyone. If you can, just take a few minutes to, fill out our brief survey to tell us your thoughts about this session, and, give us some feedback so we can move forward. And we always looking to improve future sessions. So with that said, this concludes our Disability Awareness Month event, and we want to just thank you all again. We hope to see you soon.